Good morning. Hope you can see my slides. So, we cover the topic on periapical radiopacities today. So last time we had discussed about the periapical radiolucency. Similarly, we have lesions that are called as a periapical radiopacities. So any structure or lesion that appear opaque and which are seen around the apical area of the tooth are called as the periapical radiopacities. So any radiopacities that are produced by lesions or structures around the root apex are called as the periapical radiopacities. So radiolucencies appears as dark on radiograph, and radiopacities appear as white structures on a radiograph. So we have true periapical lesions and false periapical lesions. So any radiopacity that is produced by any entities which are either on buccal or lingual to the root apex, and the radiopaque images are superimposed over the apical region, then we call it as false lesions, false radiopacities. If it is anatomically exactly in the root apex, they are true, and if it is superimposed over the root apex, they are called as the false radiopacities. So that is how it is classified. So under the true periapical lesions or the true periapical radiopacities, we have so many lesions. Example, the condensing osteitis, the periapical idiopathic osteosclerosis, the periapical cemental dysplasia, the unerupted succedaneous teeth, foreign bodies, hypersymatosis, etc. are the true periapical radiopacities. These are the lesions which are exactly related to the root apical region and appear opaque on a radiographic appearance. Apart from this, we have some uncommon lesions, rare lesions, which are the calcifying odontogenic cyst, cemento-ossifying fibroma, the chondroma, the variants of chondroma, that is a chondrosarcoma, chondrofibroma, focal and diffuse sclerosing osteomyelitis, hamartomas, osteogenic sarcoma, Paget disease, which we do not come across very commonly. Whereas the first lesion what I showed you with the condensing osteitis, idiopathic sclerosis are the lesions which we see very commonly. So under the true lesions, we have common and uncommon lesions. Then under the false periapical lesions, mainly we have various anatomic structures. So among the anatomic structures, some are radiolucent, some are radiopaque. Some of them are in the very close to the root apex, some are little distant from the root apical region. So when we discuss about the periapical lucencies or periapical radiopacities, we have to mention about the anatomic structures also. Apart from anatomic structures, we have various other lesions which are not exactly related to the root apical region, like the impacted teeth, supernumerary teeth, the complex and the compound odontomes, the tori exostosis lesions, various root fragments and foreign bodies, mucosal cyst of the maxillary sinus, any such similar lesions which we do not say, which we say which is not exactly in the apex, which are either on the buccal side or palatal side, and which may appear to be in the apical area of the teeth. In that also we have some rare lesions like the cricoid cartilage, calcified hematomas, acnes, myositis ossificans, which are extremely rare conditions. So we will discuss the features of the common periapical opacities here. Okay. So coming with the true periapical opacities, one of the common lesions that appear as a true periapical opacities are condensing osteitis. So people who are already started taking with the patient cases, you are already familiar with condensing osteitis. It is a sequelae of a pulpal and periapical infection. So what happens is, once the infection from the pulp reaches the periapical region, there is usually a radiolucency developing in the periapical region, which we call as a periapical granuloma or abscess or periapical cyst, and etc. But sometimes what happens is, instead of a degenerative process, sometimes there could be the inflammation may induce a sclerotic reaction. So there could be a sclerosis of the bone because of the periapical inflammation occurring in a non-vital or a infected pulp teeth, wherein there is a sclerotic bone reaction happens. So this happens whenever the infection is very mild and the tissue resistance is more. Instead of bone dissolution or instead of bone resorption, it will cause bone deposition as a reparative mechanism. So either the infection is mild or the tissue resistance is more, then instead of resorption, there will be bone deposition that can happen, or bone proliferation that can happen. So when there is a bone deposition or bone proliferation, we do not get a radiolucency. Instead, we get a increased bone density, creating a radiopacity. So that is what happens in condensing osteitis. So the tooth will have a history of pain or a history of pulpitis and history of decay and things like that. And in the radiographic finding, you find a increased bone density rather than a radiolucency. So the differential diagnoses include the periapical cemental dysplasia, the focal cementosus dysplasia, foreign bodies, etc. But when there is a history of a pain, history of a decayed tooth, and radiographic evidence of a pulpal disease, then the diagnosis is very easier to diagnose it as a condensing osteitis. So the treatment will be extraction of the tooth or a root canal treatment for that offending teeth. So this is how it looks like. So here you can see the tooth having a carious lesion, it involving very close to the pulp, and periapically there is a break in the continuity of the lamina dura, and in the apical area, instead of the radiolucency, there is a radioopacity in both the mesial and the distal root. When you compare with the adjacent teeth, there is a sclerotic bond reaction happening here. So this is called as focal sclerotic osteomyelitis or condensing osteitis. So this is the first and foremost important periapical radiopacities that we should be familiar about. So it happens in a tooth with having a pulpal and periapical infection, tooth with a history of a decay, history of a pain, and you are seeing a radiopaque area corresponding to the tooth having the pulpal infection. We call it as a condensing osteitis. The next periapical radiopacity that you should be familiar is a periapical idiopathic sclerosis or idiopathic osteosclerosis. So here also there is a bony condensation, there is a radiopacity because of the increased density of the bone or increased thickening of the trabecular bone, but this occurs in a normal teeth or teeth without any pulpal disease or pain or decay or things like that. So this happens without an evident reason. So that's why it is a idiopathic. When you say without a reason, it is idiopathic. There is a periapical bone change, periapical bone condensation because of any unknown or unusual cause or without any definite cause. It is called as a idiopathic periapical osteosclerosis. So this happens as an incidental finding. It may be either in the root apex, just above, just on the mesial or distal side, or slightly away from the root apex also we can expect idiopathic sclerosis. More common location is a mandibular, first premolar and the canine region. So if you watch carefully regarding the trabecular pattern, there is a dense homogeneous radiopacy that develop in the apical region with a well-defined borders, and characteristically the teeth involved area will be vital without any pulpal disease or periapical diseases. That is a differentiating factor of the periapical idiopathic sclerosis from our condensing osteitis. So there is no offending teeth or a pulpal disease, and you are seeing a similar like this where the lamina dura is not disturbed, the periapical, there are no areas of radiolucency, but you are seeing only radiopaque area, and you can confirm clinically for any tenderness, pain or pulpal disease or vitality testing can be done. If all those things doesn't prove anything, any pathological finding, then that confirms the diagnosis of idiopathic osteosclerosis. Okay, so sometimes it requires a clinical correlation also to rule out that it is not condensing osteitis. So the differential diagnosis for idiopathic osteosclerosis are obviously the first differential diagnosis will be the periapical cemental the condensing osteitis, which we explained earlier, and the periapical cemental dysplasia, which is similar to this, which we will discuss in the next slide. So that is the periapical idiopathic sclerosis. The third lesion under the periapical radiopacities, what you should be knowing, is the periapical cemental dysplasia. So this is a reactive type of lesion occurring in the mandibular anterior region, most commonly in the mandibular anterior region, and more in the females. So females of above 30 years to 50 years is usually identified, and again this is also asymptomatic, and this is self-limiting type of a disease. So you come across periapical cemental dysplasia in periapical radiolucencies, in periapical radiopacities, and also in the mixed lesions in the jaw, because it has got a radiolucent phase, radiopaque phase, and a mixed phase. That is why it is included in the differential diagnosis of both radiolucencies, radiopacities also in the mixed lesions. Characteristically, this involves multiple teeth. It is not localized one teeth as in condensing osteitis or as in idiopathic sclerosis. It is usually involve multiple teeth. That is one difference. Another characteristic difference is that here it is asymptomatic, similar to idiopathic sclerosis, and the tooth will be vital on your vitality testing. And the radiopaque area you see is in the mature stage of the periapical segmental dysplasia. So you have an early stage, intermediate stage and mature stage. In the early stage it is radiolucent, in the intermediate stage it is mixed radiolucent radiopaque, and in the advanced stage or in the mature stage it becomes prominently radiopaque. Okay, so there will be no associated any clinical history or complaints. You do not find any examination findings when you clinically palpate the area or examine the area for any bony changes or soft tissue changes will not be there, and you find it as totally asymptomatic. It is called as a periapical segmental dysplasia. The another periapical radiopacity you can see is a unerupted succedaneous teeth. So especially when you take a radiograph in a mixed dentition, you find a lot of tooth structures developing in the apical areas. So this will be exactly in the root apical region. So it doesn't represent a pathology, but it represents a normal structure. So the radiopacity will be surrounded by a radiolucent margin or a crypt, which represents the tooth crypt. So this is seen in people, radiographs taken for people who are less than 12 years or 13 years of age, where the premolars and tooth are erupting apical to the deciduous teeth. So this is one of the false periapical radiopacities because it is not directly related to the apical region. So sometimes it might be difficult to identify such lesions as a pathology or a unerupted teeth. You follow some advanced techniques to identify, or if the tooth is having a typical morphology of the crown, including the enamel and dentin caput, if is visible, then the diagnosis is very straightforward of that of a unerupted succedaneous teeth. The next lesion that you can expect is a foreign bodies. So foreign bodies may get entrapped in the tissues and may appear on a radiograph like a periapical opacities. For example, any gutta percha points, any restorative materials trapped into the soft tissues, a root canal filling material going beyond the root apex, or anything that can appear in the apical area as a radiopacity. So many of our restorative materials, metallic objects, root canal filling materials are radiographically appearing as a radiopaque structures. So this is one common finding that you can appear in the periapical area. So if there is a history of a root canal procedure, history of any dental procedure done in that area, or history of a trauma or entrapment of any metal pin or hook or anything accidentally by the patient, that is the reason for the appearance of the foreign body. So we have, most of the time you get a history of such procedure or such an injury or some trauma or something that will induce the change radiographically. Okay, so here you can see the previous one, as I told you, the unerupted succedaneous teeth, developing tooth bud appearing in the apical area, having a radiolucent tooth crypt, and you can very clearly see the crown shape and density, so that makes the diagnosis very easier. In this second radiograph, you can see the foreign body in the root apical area. Maybe some retrograde filling or something has been attempted here. You can see like this. Another periapical radiopacity you should be familiar is a hypercementosis. So as the name suggests, hyper is something that is excessive is called as hyper. Cementosis is a cementum. So there is a excessive cementum growth is called as hypercementosis. It's also called as cemental hyperplasia. So what happens here? There is over deposition of cementum along the root. So normally radiographically you cannot identify the cementum because cementum is a very thin layer. Secondly, the cementum has got the same density of that of the radicular dentin. So we will not be able to differentiate the cementum or identify the cementum on a radiograph because of these two reasons. It is having the same density that of the radicular dentin, and it is a very thin layer, so that it doesn't make it very distinct from the radicular dentin. But in case when there is an over deposition of cementum, there will be change in the morphology of the root structure. Okay, so what is the reason for excessive cementum? It is not very clear. It could be due to supra-eruption of the teeth. It could be because of the periapical infection. It could be sometimes due to systemic diseases like Paget's disease, acromegaly, etc. So here the involved teeth will be usually asymptomatic and the tooth are usually vital. It doesn't have any correlation or any relation between pulpal or periapical diseases or periodontal diseases. Here only the cementum layer is exaggerated or overgrowth or development of the cementum layer is happening. So how we can make out, so this is an incidental finding on radiograph, we will not have any finding, but the only clinical significance that the treatment, like you want to do the extraction of some teeth having a hypercementosis, the extraction might become difficult because of the mechanical locking of the cementum area, or this bulge area will become very resistant to extraction or difficult to extraction because of its more mechanical locking. So radiographically what you find is, you see a smooth enlargement of, it looks like there is a smooth enlargement or bulging of the root within the confines of the periodontal ligament space and the lamina dura. Most of the other periapical radiopacities, they develop outside the periodontal ligament space, outside the lamina dura, whereas the cementum is a layer that is same within the periodontal ligament space. That is why only in hypercementosis the radiopacity is inside the periodontal ligament space, and that is a significant differentiating feature of periapical cemental dysplasia from, the differentiating feature of hypercementosis from PCOD or cementoblastoma or condensing osteitis or any other lesion. All the other lesions, the radiopacity will be outside the periodontal ligament space, wherein hypercementosis it is within the periodontal ligament space. So that is a single most differentiating feature of hypercementosis from the other periapical opacities. Then we come to the rare lesions like the cementoblastoma. Cementoblastoma is a rare lesion, but arising again from the cementum. It is a slow growing benign neoplasm appearing like a bulbous growth. It could be usually solitary or single teeth or root, usually involving the permanent teeth in the mandibular, premolar or molar region. But here disparity to the or differentiating from the hypercementosis, doesn't remain confined to the periodontal ligament space. It grows beyond the periodontal ligament space, and it shows some pain and pressure symptoms, and it will have a radiolucent band around the radiopacity. There is an area of radiolucent band around the radiopacity. So these are the differentiating feature of cementoblastoma from the other periapical radiopacities and hypercementosis. So hypercementosis is a benign overgrowth of the cementum which remains confined to the periodontal ligament space and which doesn't show any aggressiveness, whereas the cementoblastoma shows some sort of aggressiveness. It shows some amount of growth potential and pressure sensation to the adjoining structures. Another rare lesion is a Paget's disease, which is not confined to one root or one area. It involves the entire bone or a large part of the bone. There is abnormal bone deposition and bone resorption in multiple bones. It will leading to morphological changes, prognathic mandible, prognathic maxilla, depending upon the bone it is involves, and the facial feature all shows changes. In a periapical area, it will show an increased area of bone deposition leading to a sort of periapical radiopacity. Then in osteogenic sarcoma, you can see increased density of the bone giving a altered trabecular pattern. More and more bone deposition happens on the periosteal area, in the medullary area, etc., giving to a sunburst or a sun ray type of appearance. So because of this vertical orientation of this trabecular pattern, which is oriented towards the periphery, projecting towards the periphery, it gives like a sunburst or a sun ray like of appearance. So that is a characteristic which are in osteogenic sarcoma. So for the completion's sake, we should include such lesions also in the periapical radiopacities, but it includes in the rare lesions or rare condition that cause periapical radiopacities. Now coming to the false periapical radiopacities, which is not in the root apex, which is projected over to the root apex. They are called as a false opacities. In this, first and foremost is the anatomical radiopacities, like so many structures you see when you take the radiograph, the cartilage of the nose, the mylohyoid ridge, the floor of maxillary sinus, the zygomatic process of the maxilla. So you get structures in the maxilla and structures in the mandible, which will radiographically look like radiopacities. So they are called as the anatomic radiopacities or anatomic landmark that appear as radiopacities. So that should include in the differential diagnosis of the periapical radiopacities. Then we have the impacted teeth. Impacted teeth is a common finding in our dental radiographs. Impacted teeth could be the third molars, the mesiodents, the paramolars, etc. We have studied in our oral pathology. So impacted tooth can be usually impacted supernumerary tooth or impacted normal teeth. Okay, so they will appear in the apical area of the remaining teeth which is already erupted. So this will have a normal density of the erupted teeth. That supernumerary tooth will have a normal morphology of the erupted teeth. It will have the normal density, morphology and appearance, and it will be usually surrounded by the tooth follicle which will appear like a radiolucency. So we can identify the position, we can identify or confirm the supernumerary tooth by taking multiple radiograph, by taking CBCT, etc. Usually we identify and then we decide whether it has to be removed or it has to be orthodontically erupted, as orthodontic assisted eruption has to be done or a removal has to be done after identifying the location and confirming it as a supernumerary or an impacted teeth. As you can see, some of the supernumerary impacted teeth here. There is mesiodents occurring in the maxillary anterior region. Another one which is seen here. Then we have odontomes. Odontomes are similar to supernumerary tooth, but these are considered to be hamartomas because they represent like a tooth, but they are not real teeth. So they are odontomes are either compound odontomes or complex odontomes. So compound odontomes are very similar to tooth structure, usually seen in the maxillary anterior region, and they are surrounded by the radiolucent structure, but the morphology is different from a supernumerary tooth. It has a combination of enamel, dentin and pulp-like structures, but not in a normal proportion like how you see in a teeth or a supernumerary tooth. Then we call it as a compound odontoma. Complex odontoma has got very little resemblance to the tooth structure. It is seen mainly in the mandibular posterior region, not in the maxillary anterior region. And complex odontomes are also surrounded by a radiolucent spaces. So that is two different forms of odontomes. Okay, so you can see the pictures here. The complex odontome in the maxillary anterior region, another complex odontome in the mandibular posterior region. Okay, here you can see one tooth with a similar to tooth structure. So this is a compound odontome, and this mixed up type of lesions which doesn't have the morphology of a teeth, this is a complex odontome. So we have both examples here. Then we have another periapical radiopacity, that is a tori, exostosis and osteomas. These are bony lesions which is seen in the radiograph as a periapical pathology. So these are situated in the periphery of the jaws and they originate deep to the surface epithelium. They arise from the cortical bone below the surface epithelium. So they are slow growing, having a smooth surface or smooth contour. They can be single or multiple. They are rounded, dense radiopaque masses because they represent exaggerated growth in the bone. So even they are in a specific location, they are called as tori, like the palatal tori, the lingual tori are in the particular specified locations. If it is haphazardly occurring in the here and there, it is usually mentioned as exostosis. It is an excessive deposition or bone formation which will be clinically palpable. In our idiopathic sclerosis, there is no clinically palpable swelling or demonstrable swelling, whereas in tori, exostosis, osteomas and all, we have a well identifiable clinical growth or a swelling is palpable, which will be very firm in consistency or bony hard in consistency, look like a very bony growth or a bony prominence compared to our idiopathic sclerosis, condensing osteitis or other pathologies that appear in the periapical area. So to diagnose it as a tori, it will be either in the palatal side, or it will be on the lingual side in the mandible, or the palatal side in the maxilla. Exostosis, when they are palpable as a small swelling which is located in the other areas, the labial areas in the anterior region or lingual side in the other areas other than the lingual and the palatal tori. And osteomas, when it can be considered benign proliferation in the bone, it is called as a osteomas. It has to be having a growth potential and having a benign proliferation, it is called as osteomas. Whereas tori and exostosis are just a developmental type of anomaly or which cannot be considered as a benign neoplasm, it is called as a tori and exostosis. Foreign bodies, already I told you, it can be classified in the true periapical as well as in the false periapical, because false periapical, if it is located in the cortical plate, if it is located in the buccal vestibule or in the palatal region, it will project on the apical region and create a false periapical radiopacity. So foreign bodies includes in the true periapical as well as in the false periapical opacities. So the foreign bodies usually are the restorative materials, pin, hooks, metal fragments, etc. It could be in the buccal vestibule, in the buccal mucosa, or in the gingiva, and appear radiographically as it is in the apical region. So false periapical radiopacity includes the foreign bodies as well. Then pathologies in the maxillary cyst, in the maxillary sinus, like the mucosal cyst, sometimes even some calcifications in the maxillary sinus will also appear as a periapical radiopacities. So it sometimes doesn't have any clinical findings. It could be identified on a radiograph. When take a radiograph, you see some pathology or radiopacities in the apical region like this, which is corresponding to the maxillary sinus. So we have to differentiate it from after correlating with the clinical findings, and sometimes we may have to go for a CBCT or other imaging modalities to confirm that it is a sinus pathology, because in a two-dimensional radiograph like an IOPA or OPG, we will not be able to differentiate whether the pathology is in the root apex or is it in the sinus. So we require advanced imaging modalities or advanced techniques to differentiate. Then we have ectopic calcification, that is calcification occurring in the soft tissues. Okay, so, they may appear in the periapical area. For example, the calcification in the submandibular gland, that is called as the xyloliths. Xyloliths may appear in the mandibular molar region corresponding to the submandibular gland. Okay, and it may occur also in the parotid glands. So more commonly, the submandibular xyloliths may occur radiographically as a radiopaque masses in the root apex. So we can confirm it by clinical correlation, by using xylography, by using advanced images. So apart from xylolith, even calcification in the maxillary sinus, which is called as androlith, calcification in the maxillary sinus. Any chronic inflammation or infection may get calcified, leading to radiopaque structure in the maxillary sinus. So this is an example picture of a androlith. You can see a homogeneous, dense radiopaque structure in the maxillary sinus, which is not rising from the floor of the sinus. Other pathologies like the maxillary cyst and all will originate from the lining, but this is not originating from the lining, and it is densely, homogeneously radiopaque. So this is an example for androlith or calcification in the sinus. Other calcification arises from the lymph nodes, that is the cervical or submandibular lymph nodes. Mainly calcification occurs because of tuberculosis. So they may be identified as a routine when you take a radiographs, OPGs or IOPS for routine dental purposes. It may involve any node as a single or ovoid radiopacities. They have well-defined contour and outlines. So you can see an example of a calcified lymph node in the submandibular region here. That to correlate with the clinical findings. Then we have various artifacts. This is an artifact example, lens of a glass. So any foreign bodies or artifacts because of improper patient positioning or not removing the objects from the face, that may create a radiopaque structure in the radiograph. So artifacts will be some earrings in the OPG, or nose rings or nose studs in the IOP may appear as a foreign body, or glass, as you see here, the frame of the glass, or eyeglasses, sunglasses, that can create a radiopaque shadow in the apical area. So these are the various periapical radiopacities. So as I told you in the beginning, basically we need to know the classification, that is the true periapical opacities and the false periapical radiopacities. In the true, we have various pathologies related to the tooth and the pathologies not related to the pulp and periapical area. So each of this is very common, most of them are very common, and we should know to differentiate and identify radiographically and how to differentiate one pathology from the one finding from the other finding. And anatomic radiopacities already you are familiar, so that is the topic on periapical radiopacities. Okay, thank you.